Everybody, welcome to this second surgeon to surgeon episode. Today we have a great privilege to step in the OR with Roger van Riet, who's our actual president of the SECEC Society, and also is incontestable elbow surgery master. So it's a nice symbol to have elbow surgery performed by you, Roger, today. Thank you very much.
Okay, so welcome everyone to our arthroscopy live surgery. We're having some technical difficulties. It's the first time we're in a brand new OR. And it's the first time we're trying something like this. I have some special glasses on as well from Rods & Cones, the company that's helping us and supporting us today. So hopefully this will all work out well. This is a 14-year-old girl with a history of elbow pain for about a year, or a little bit over a year. And as you can see, she plays volleyball competitively. And as you can see, she has a irregularity on the lateral side of the capitellum. And this is, of course, suspect of an OCD lesion. She has locking and clicking. So as soon as you hear the words locking and clicking, you get imaging. And as you can see, she probably has a big loose body at the front of the elbow there. So we're going to do an arthroscopy to remove the loose body, to evaluate the cartilage, and to potentially remove some of the cartilage as well, or at least to stabilize the cartilage. We're not planning to do any oats or any replacement today. So we'll have a look, see what it looks like. So our team is already getting ready to prep and drape the elbow. So the elbow has been prepped, and hopefully you can see this. Hopefully I'm pointing in the right direction with my glasses. But you can see we use a tourniquet, and the arm is completely free. So the elbow, there's nothing pushing on the elbow at the front of the elbow, which I think is the most important thing. We use a very simple roll that we borrowed from the knee surgeons that use this for ACLs to support the foot. And we've been doing this throughout my career, and we're resting the tourniquet on top of the roll. And this way the elbow is completely free. The other arm is on an armrest. The IV drip is in the hand, it's not in the elbow, because otherwise sometimes it stops working as soon as you flex the elbow. And patient is intubated and lying on a normal pillow, nothing special, just a normal pillow, because this can support between the bed and the armrest. So when the patient would fall a little bit forward, at least they won't get into a void. So this is our normal arthroscopic setup, and our guys are now going to prep the patient. I'm going to wash. And then we'll start the procedure. Wil je maar afdekken, hè? I've already washed, so I'm just going to use some alcohol.
Thank you, Roger. So, if you have any questions during this webinar, please don't hesitate to ask them via the chat, and we relay them to Roger if he can hear us. Roger, can you hear me now? Or?
No, much better than before.
Perfect.
So the people that are prepping and draping are Alex, my nurse, is always with me.
Operate on them under general.
Sarah, sorry. Go ahead, Gregory.
Yeah. Do you operate always general anesthesia in this position? Because I find it a bit uncomfortable.
General anesthesia, yeah, because it's very uncomfortable for the patient. Very uncomfortable for the patient to lie on the side. You can add a block in afterwards if it's painful. I prefer to do it afterwards so we can at least.
Any tips and tricks?
Any tips and tricks? On the position, you mean?
Do you have any tips and tricks for the preparation of a good access to the anterior compartment for the installation?
Yeah, hopefully you'll see that in a second. But the most important is not to rest the arm on the arm rest. It doesn't matter if you use a fancy arm holder or you use anything else, but you're not allowed to rest it on the arm rest. So the antecubital joint space has to be completely free of any compression. That's the most important thing. If you don't have that, then don't start the arthroscopy and redrape or reprep or whatever you need to do, but make sure that that doesn't happen. I think I've lost
the management again. Of your patient so far? Did she undergo any conservative measures, or was it?
Sorry?
Didn't she undergo any conservative treatment, this lady, or it was clear from the start?
No, she came to me after a year, so she had physio, she had no injections, and she's only 14 years old. But she had a lot of physio, and people said it was nothing, and everything's going to be okay, until a sports physician did an MRI and then found a big loose body. So then they came to me. Tafel mag nog een beetje lager. Okay, so maybe I'll show you again. I'm not sure if you can see this well, but tourniquet is here. The support is here under my arm, and then the elbow is completely free. Now, if I want to extend, that's no problem. If I want to rotate or I want to do varus valgus, that's no problem. If I want to flex, we flex up like this. And that's why I don't use a formal arm holder, because in some of them, they have a strap. And then it's very difficult because the other arm is in the way I position it. So we go up like this, and then we can flex it completely. Mogen wij een lampendop ook?
Very nice.
So we're just preparing. It takes a couple of minutes, but I didn't want to prepare before because I think it's too important for everyone to see how we position the patient. I think that's probably key in elbow arthroscopy. Some people have told me that it's sometimes difficult to get into the medial side, but as you can see with the arm holder that we use, it's not in the way at all. We can actually get all the position that we want with our trocar. We use a specific
Roger, do you have any indication to scope?
What are my indications for scopes?
Supine position sometime?
No, was the question, what are my indications for
supine
scopes?
Position?
For position, I always position lateral.
No,
always.
the indication for... Always, okay.
For every indication for arthroscopy, yes, always. Not too much, no, you know.
Standard scope, 3.5.
I'm sorry, Greg, but it's really difficult to hear you.
No worries. I'll yell.
Okay, we're ready to go. So, I use the skin marker. With the skin marker, I'm gonna put this. Kunnen wij de lampen wisselen naar de lamp alsjeblieft, het beeld van de lamp?
Ja.
So, if everything's all right, you're now seeing the elbow from a different view with the light. Kun je daar ook even die op de lamp zetten?
Yes.
Die op de lamp? I'm sorry, I'm rotating my head a little bit. Maybe you don't see it, but I've just asked the nurse to put the image of the light onto the screen that we have. We have a big screen, and then I can see it myself a little bit. So you see the arm now from the top. Here's the olecranon. Here's the medial epicondyle, and here's the lateral epicondyle.
Yes,
and I draw. I always do the same. I palpate the ulnar nerve, flick it a little bit. It's here. It's in the groove. It's not dislocating, and I draw the ulnar nerve. Now I know this is the medial side, and it doesn't matter what you do as long as you draw the same every time. If you want to draw a little X or a cross, that's fine. My second drawing is the lateral side of the olecranon, and this is it. This is all of my drawing on the elbow, and now I know this is medial, this is lateral, and I don't get mistaken during the case because left and right looks more or less the same, and you do not want to end up on the medial side when you think you're lateral. That's very important. I think that's a very important point to do. You can draw as much as you want. You can draw the radial head. You can draw the LCL, and sometimes I do for demonstration purposes. But in this case, ulnar nerve, lateral side of the olecranon. Then we start with insufflating the joint. I know some people use dry arthroscopy, which is fine. You can insufflate with air if you want to. The biggest problem with air is that you need to keep on getting the flow going, and I haven't found a really good system to keep the flow into the elbow. Maybe I'll draw this for you just for the demonstration, but the tip of the olecranon is here. The lateral condyle is here. And then the radial head is sort of, in my mind, the radial head is here. But we know that it's this is a difficult word for me, isosceles triangle. And in that triangle, the center of the triangle, this is a soft spot. So then when we go in with the needle, and I hope this works, because in children it's always a little bit, and especially OCD, when the lateral capitellum is a little bit irregular. But normally, if you go in like this, perpendicular to the skin, should fall into the joint. And of course, there it is. So I'm in the joint now. Then we inject. Just keep injecting, and you see the arm move. I'm not sure if you can see that.
How much can you usually inject?
Between 30 and 35
you
minutes.
Can see it.
Yeah.
You can see
but there's a little girl, so she has about 20, and then when I let go of the plunger, you see how the plunger sort of comes back. So that's fine. That's enough for me. I was trying to tell you earlier, but I use a special tip on my cannula. This tip does not have any side flow. So in the normal knee and shoulder arthroscopy cannulas, they have holes on the side. We don't have that. So we only have flow on the outside, on the exit point. And that helps us a lot, because if you're only in this far in the elbow and the hole is there, then the soft tissue gets pushed into the joint as soon as you open the fluid. But if you have outside flow or outflow or whatever you want to call it, distal flow, then the soft tissue will be pushed away from the cannula, because the water will sort of come in here. Okay, now the first portal. I'll move the camera again.
Very interesting.
We can go back to the head set, but then you have to let me know whether I'm in the right spot, because I don't see myself with the headset. Can you see the medial side of the elbow here?
Yes.
So this is the medial side of the elbow, and we know, I'll draw this again.
You can see it.
So this is the medial epicondyle. We already drew the nerve, but it's important to sometimes, check it again anyway, because the nerve can move because of the swelling of the tissue, medial epicondyle. And when I was taught arthroscopy, they told me the intermuscular septum is extremely important. And find the intermuscular septum, and then flick it maybe even with your cannula, but don't do that. Intermuscular septum, it is important, but it's important to stay anterior to it, because you don't want to go behind it, not even to feel it, because it's very easy to irritate or even catch the ulnar nerve. My first portal is about 1.5 to 2 centimeters proximal, and about 1 centimeter anterior to the intermuscular septum. So that's where my first portal is, and it's important to make the portal, to only make the skin portal. So I incise the skin a little bit deeper, but I don't go deeper than that. That's it. Then we have the cannula. Cannula goes in on this side. And then what I do first, I go in, I pierce the capsule. There you go. And now I'm anterior to the elbow. I'm sure I don't need to find the intermuscular septum. I just find the anterior part of the humerus. And now I know I'm anterior to it. I'm not in the joint yet, hopefully, because I don't want to take the fluid out. Then I pull back until I feel that I'm at the end. And then we go in towards, hopefully between radial head and capitellum. Radial head and coronoid. Now, if I'm in the correct spot, then fluid will come out of my cannula. And I've been tricked before when I was a little bit less experienced.
Yeah.
Fluid came out, and I was really happy. Everyone's happy when fluid comes out, but then my tab was on. So make sure that your tab is off before you do this, because fluid comes out anyway if the tab is on. Then we'll go to the arthroscopic view. You see the arthroscopic view now?
Yes. Yes.
Perfect. This is a radial head.
What is your pump pressure? Pump pressure?
Oh, sorry, I didn't talk about that. But if you look, maybe back to my headset.
Yes.
So you see that little bag there hanging?
We see it.
Well, I use pressurized saline bags. I don't use pressure. I don't use a pump. I'm
raise your head.
A simple person, and I've been taught like this. And so I have about 120, 110 millimeter hydrogen pressure on the bag. And then if you look at my cannula, this is the pressure I want. You see the water?
Yes.
About
Sorry, Roger.
10 centimeters.
That's my again. Yes.
Yes. Can you see it?
Yes.
Okay.
Like
This is what this is pressure. So I can't explain to you how much my pressure.
Just show us again your bag.
The bag? Oops.
Sorry, Roger.
Sorry, I'm stepping on all kinds of pedals.
Yeah, just show us again your setup.
Can you see the bag or not?
If you can raise your head a bit. Yes, just raise your head a bit. Look up a bit. I think
again?
Better. Yeah, that's good.
That's okay. That's perfect.
Thank you.
It's very cheap. Make sure you don't inflate it too much, because sometimes they explode, and then everyone gets scared a little bit. Okay, now we go back into the joint with our view. So there's a radial head. If you're not sure, just rotate a little bit. She has quite a bit of laxity. See how I can go in between the annular ligament and the radial neck, which is not normal. Normally, you can't, but she's, like I said, she's a little girl, and a little girl sometimes a little bit more lax anyway. So that's possible that this is still physiological. You can already see the OCD lesion a little bit from the front. See how the elbow, there's some irregularity on the cartilage there. Then we go and look at the medial side. There's the coronoid. Look at the little gutter that's next to the coronoid, and there's the loose body. So on the MRI, the loose body was actually in the coronoid fossa, but it moved and it's here now.
Do you consistently find them?
Sorry? There it is. See it?
Do you have some regular spots to look for them?
Yes, and the medial gutter, and of course in the fossa, because sometimes they're stuck. Sometimes they're not loose bodies, but they're stuck bodies, and then they're stuck here. You see how it made a little damage on the cartilage there? That's it. So we need to grab that loose body. Now, we'll go back to the outside. Can we have an outside view and inside view at the same time? And maybe from the light?
Yes, we can do that.
We can do that? Perfect. So sometimes you hear the people from rods and cones, they're helping us, and without them, it would not have been possible to do this at all, because like I said, this is the first time in the new hospital. We've only been here for a few months. And in fact, last week, when we tested, or the week before when we tested, the internet wasn't good enough. And our IT from the hospital has really, really stepped up, and they've, together with people from Arthrex, I'm not involved with rods and cones, Arthrex, unfortunately, nor the hospital. But they have helped us a lot, and without them, it would not have been possible to do this live surgery. So you see inside, you see me pressing on the lamp view, and you see me pressing the capsule there inside. I get a needle. It doesn't matter what kind of needle, just whatever needle you think is appropriate for you. I like using a big needle because the smaller ones sometimes bend a little bit, and I'm not very gentle, I think, so I like to use a bigger needle. And then you go in. And you see, I'm in here, right? You see me inside, see the needle? And what's very important, and hopefully you can see that, well, you can see that a little bit from the lamp. My needle is parallel to me and parallel to the floor. And that's extremely important, because now I know I can go in and out blindly without any problems. I know exactly, I can close my eyes and I know exactly where the needle is. I don't like this portal, because when I go in, the capitellum is already touching my needle. So it's very difficult now to find the loose body. So this portal is actually a little bit too posterior for me. I'll squeeze this loose body into view again. Well, it is possible now because I squeezed it in, but it's more difficult. So I want my portal to be a little bit more anterior to this, because otherwise I'm afraid that the capitellum will be in the way. Mission. So I use a 15 blade. Because when you're using sorry?
Yeah, how far interior can you go before you come out the radial nerve?
The nerve is
how far interior can you go?
If you look at the tip of the needle, the nerve is about. Oh, sorry, I fell out. The nerve is about here. So between, let's say 6 o'clock and 9 o'clock on the radial head. So the nerve is all the way here. And I use quite a lot of pressure, as you can see. So you can go very safely all to there. Very safely. So we're not going to replace the needle because I know where I want to be. So I just make my stab incision anterior to it. Yeah, go. Took the needle out. I go in. And then when you look at the inside, you see the capsule there bulging a little bit? That's my blade. Now, if you use an 11 blade, that means that you have a little tip to cut, and you're cutting the skin quite a bit. And I don't like that. I like the capsule to be cut, but I don't like the skin to be cut too much. So I know, okay, I'm going in, stab it. I know it's a big loose body, so make the portal a little bit bigger. And like I said, it's straight in, straight out, right? I think this is safer than using a blunt instrument, and at least it's, if not safer, then at least it's easier, because I can now grab my get my grasper, and I know I'm going to get in without any problem. See that? In and out, without me looking even.
No cannula.
No cannula, no. Okay, now squeeze on the inside of the elbow. Inside. Nee, dat is de achterkant. The front. Hang on. Hou eens even. Kom. Nee, dat is het niet. Here. There it is. So squeeze it into my mouth. I wanted to say something rude, but I stopped myself, which I think is very, very well done. When you have a mobile one like this, Sometimes it's difficult to grab it, although it just fell into the mouth of the grasper. However, you can see that my grasp is a little bit too small. So every time I want to close it, it disappears. I have it now. I have a good grasp. So now I can be brave and take it out, but I really do not want it to break under the skin because that's really annoying, especially in live surgery. But I'm going to do it anyway because I'm very impatient. And there it is. All right. So we remove the loose body. That's only part of the surgery. You see, there's not a lot of inflammation. There's a little bit of synovitis. I'm going to give this to Alex. We put it in a jar and the patient gets it. A little bit of synovitis, which has perfect motion. So we're not going to do anything to the synovitis. It will go away when we take, because we took the loose body away. I think that's probably the most important thing. It's not a very exciting surgery, but I took this one because we only had an hour, and I really, really wanted to see. I wanted to show you how to do the setup because I think that's the most important part. I forgot to take pictures, but I hope we're taping this for the patient. Although she didn't want to see it, she didn't want to see what happened. So again, radial head, coronoid, little fossa next to the coronoid where the loose bodies try to hide. You have to try and see this during your arthroscopy. Then you go up. So I always do the same square. Go to the coronoid fossa, which is fine. There's nothing there, and go to the radial fossa, which is there. Again, nothing there. Lateral portal is here. It's an anterolateral portal. You can switch portals if you want.
Would you flex the elbow? Show us how high you can go.
All the way up. This is 90 degrees. This is 130 degrees flex now. That's of course a little bit challenging because it's quite easy to lose the elbow now and fall out of the front. So now we're going to the back, which is going to be more important because the back is where the where we're going to see the OCD lesion, of course. So we have the camera on the light. Again, I'll grab my my skin marker. So this is the lateral side. Maybe we'll go to the headset again. This is the lateral side of the elbow.
Mm-hmm.
Is the view okay, Lieve?
Yeah, absolutely. Yeah.
Okay, very good. So this is the lateral side of the elbow that I just marked. Many people make the first portal quite proximal, and I think in most textbooks it will say about 1 or 2 centimeters proximal on the lateral side of the olecranon, or central posterior, which is this portal, which is about 2 centimeters proximal to the tip of the olecranon. This one I use as a working portal and not as a viewing portal because I'll show you that later. From the portal that we use, it's much easier to get into the lateral gutter, and that's where we need to work today. So today we're not working too much, hopefully, in the back, but hopefully we're working more here. So my portal is more distal to the classic portal, or my portal. I don't know who described this portal, so I'm sorry for the person who thought about this. Right on the lateral side of the tip of the olecranon. So I drew the tip earlier, right there is the lateral portal. Right, then we use a knife. Again, 15 blade. Go in. And I go in all the way to the lateral column. So here's the bone. I'm on the bone of the lateral column, the lateral humerus. Then I turn my knife around, and then I sneak underneath the triceps. And you saw me fall in, and now I'm in the gutter. So now my knife is all the way in. She doesn't have a lot of pathology there, so I don't need to scrape it or don't need to do anything. But normally, you sort of already get a feel of what's going on in the back with your knife. So again, trocar, blunt tip. That's important. I forgot to say that before. We do have a double inflow, or you can use it as an outflow, but we don't do that. I only use one. It's nice in the beginning of the case when I want to fill my syringe, but it's not necessary. One would be enough. More important to have only distal outflow. That's the most important part. Let me go in. Same way as my knife. So I go on the lateral column, and then I sneak underneath the triceps. So now I'm underneath the triceps, and my trocar is in the olecranon fossa. I can feel that. I can feel that very nicely. And then this is a tip that I think is very important. And so, Gregory, can you see the end of my? Can you see my hands basically?
Yes. Yes.
Okay, perfect. So now we open this.
Yep.
And what I do now is my trocar is still on the bone, and I push the cannula in. I push the cannula in so that the cannula now, the tip of the cannula is now against the bone. Whereas if you do it the other way around, so what normally happens is you leave the cannula where it is. Let's say this is the bone, the edge of the sheath there is the bone. And now when I pull back, you're 5 millimeters away from the bone. And we don't want that. So we want to be on the bone because there's usually some soft tissue there or the fat pad is there, even in relatively normal elbows. So what you do is you leave the trocar there and then you push the cannula on it. And then you remove the trocar so that the trocar is on the bone. I think that's a very important tip that we use basically all the time, even without thinking now. So sneak underneath the triceps again, go in, open it up, push it in.
Great demonstration.
Remove it. We grab the camera. Okay, and now we go to the inside view. And most people that do elbow arthroscopy will recognize this inside view because you don't see anything, right? That's normal. That's normal for me as well. So the inside view is always this. Very difficult view. So what I do then is I wiggle around a little bit and I go to the medial side. So there's some stuff in the fossa, not a lot, but there's a little bit there. Go to the medial side and there's the medial gutter. So there's the nerve. I'm teasing the nerve with my finger. The nerve is here. This is the ulna, the one that moves. And then at the top, you see the humerus. Now, I have a look in the medial gutter, especially in people with loose bodies, because we know from the MRI there was a loose body already, and we removed that. But who knows? Maybe there are more. Very often we do CT scans, but because she's underage, of course, we try to do as less radiation as possible. So what I do now is maybe go to the lamp again, the light view.
Yeah,
so you see my finger on the gutter. Now, if there is a loose body in the gutter,
yes,
it will pop out now. So I'm trying to milk it. And there's no loose body. Can we do picture in picture? Is that possible?
We have both pictures next to each other.
Oh, great. That's great. So we're milking it and nothing comes out, so that's fine. The second thing that we do here, and I'm actually levering with the camera, and I'm trying to open the medial joint side, the medial side of the joint. Nothing's opening. So this patient is stable on the medial side. Very important. So basically my camera, my cannula is hooked behind the capsule or the triceps, and I'm opening it now. And if this is unstable, it actually opens quite a lot without adding a lot of valgus torque. So this is really, really straight onto the medial side. Then we go and follow the tip of the olecranon. There's a tip. Now I change my side and look up. Here's the olecranon fossa. And this to me looks more or less normal. Olecranon fossa, maybe a little bit of fibrotic tissue, but really more or less normal. You can clean this up, but the reason why I'm a little bit hesitant to do this, when we clean this up, we go through the central posterior portal, and the triceps doesn't like having, being penetrated by knives and instruments. In athletes, we sometimes use a different portal, which is on the side, which is a portal where we go underneath the triceps again, which is definitely possible. It's like a little bit more proximal than the standard posterolateral portal, but it's definitely possible to go in and to do that. Sometimes it's a little bit difficult to triangulate. So for me, this is good enough. I can remove that little bit of fibrosis, but I know by doing so, I'm going to add much more fibrosis, so we're going to stop doing that. Then go back to the medial side, because that's my viewing point. I can always find it, and we always know where the medial side is. And we follow it again to the tip, and follow it as far lateral as I can. As far lateral as I can. There you go. And this is where I want to be. And she's already given me a little bit of a struggle, so it's not going to be that easy to get in. I'm going to go back, if I can. Again, tip of the olecranon, go in. And you can see that I fell out. And that's not abnormal that happens. So you fall out. What I do now is, to avoid me falling out, I'm extending a little bit. And while I'm extending, the soft tissue will give way. See how it opens up now? Obviously, it didn't want to do it the way I want it, because I was pushing it with my thumb. But there we go. So now, without pushing, without any force, we're going into the lateral gutter. Again, this is a view. This is a normal view in the lateral gutter. Turn your camera around, and then we see another loose body that was unexpected, which is good. And there's a radial head. So this is a really nice illustration of how you need to see all the compartments, because this one was We thought there might be a loose body in the back, but definitely not in the radiofemoral gutter. There's a radial head. There's a loose body. Who's been sitting there in the bare area. This looks awful. The loose body sitting there, but that's the bare area. So we're not worried about the cartilage there. That's fine. That cartilage, most people will not have cartilage there. Maybe the crater is a little bit bigger than normal, but this is probably the one that was blocking and locking and giving us problems. There you go. We open it, leave it in there. There's a radial head. There's always, some people call it plica, some people call it synovial fold. There's always some tissue in the way that will not let you have a great view. So we grab a needle again, and we go into the soft spot that I made earlier. Soft spot portal that I made earlier, or I mean the soft spot needle wound that I made earlier, puncture wound that we made earlier, and there you go. That's my needle. So I know now, okay, I'm in the correct spot for the soft spot. I'm happy here. And then we grab the knife, remove the needle, and go in. I'm just quickly looking at the time. I think we're fine. So go in. Notice that you don't see my knife that well, right? So I don't push my knife in all the way because I don't want to cut the cartilage too much. And sometimes even by being very careful, you still nick the cartilage a little bit, which is probably not a problem, but it doesn't look nice on the X-ray on the pictures.
And on the live surgery.
And on the live surgery, yes. But I'm going to tell you, it was already there. Okay, the batal?
We believe you.
Just wait, it might not be there. Maybe we're lucky. So then, it's normal to have difficulty to see the tip of the shaver. So what we do is I just shave a little bit, and you see how the tissue moves? Well, if I know that the tissue moves, then I know that I'm in the right spot. There you see my shaver coming through. I use a suction a little bit, which we don't use at the front. And then as soon as my shaver is through, then we remove the synovial fold or the plica, or like I said, whatever you want to call it. I'm not using suction too much because I don't want to lose that loose body, which is sort of in the back of my mind, because once you see a loose body, it has to come out of the joint. You can't ignore it anymore. So you need to not lose it. You need to find it again. So someone made a linear dent into the cartilage there, but luckily in the bare area. It wasn't me, huh? Okay, so grab the loose body. There it is. Take it out. Give it to Alex for the jar so the patient can get it. And that's the most important part that we've done. Now you can test the lateral stability. There you go. It's stable. It stays stable. If we use axial traction, it will open up a little bit. If you add supination, you see that she's a little bit lax, but she's definitely not unstable. And there you see the remnants of the OCD lesion, which is probably already withered out a little bit. She does have some bony edema, but not a lot. And she's 14 years old, so she's maybe, although 14 of course is very young, but she's maybe on the older side of the OCD, and she's been having this problem for a year. And the reason for surgery was the loose bodies and not necessarily the OCD. And we know that after a year, we're not going to be we're very unlikely to fix this arthroscopically or open. Now we go in again. See if I can find myself again. There I am. Trying not to suck too much, literally and figuratively. And now I'm just going to debride a little bit of the cartilage there. Bless you. Someone coughed in my ear. The people here didn't hear that. I heard it. Okay, I'm just cleaning it a little bit, and then we're going to grab a teaser and see how stable all this is. So I can already see this is very unstable. So this is a new loose body waiting to happen. See it? This is definitely going to come loose. We need to do something there and clean it up. So I'm just going to clean around it first. So it's very difficult for me to operate without music. I do like talking during surgery, but normally not about the surgery itself, but about cars and stuff. About last week, we went to New York on vacation for Halloween. That was really good. So I prefer talking about stuff like that. And then
what was your disguise?
Sorry, my disguise. I was actually. Sorry, go ahead.
Your disguise. What were you disguised as?
What I was, yeah. So I was a Canadian ice hockey player because I got a gift, a Canadian Toronto Maple Leafs ice hockey shirt. So I wore that. But then someone warned me that apparently that's a big thing in New York, ice hockey, and I was going to get my my ass kicked if I didn't take it off. So I did take it off after a while. But also it was very warm. It's not because I was scared. It was just because it was so warm. I had to take it off. And my son was a skeleton.
That's more classic.
yeah. He's only 5, so for him that was good. He's still eating the candy. He hasn't slept since then. Okay, so now we've cleaned the OCD.
What's your management?
Sorry?
What's your management plan when you see that? What do you think about now?
What am I thinking about now? Cars and food. But when I see this, this to me is a now a very stable bed. We need to remove that piece of bone there, of course. There's no way this will heal. I mean, you can fix this with whatever you want, but I'll show you. I'll shave it a little bit. Normally I don't do this. Normally I just remove it. But you'll see that the bone is yellow, whereas the bone in the bed is red. And that's what we want. So the yellow bone is not going to heal on the red bone there, unless you're really, really lucky. But like I said, she's 14. She's had problems for more than a year. Locking problems for more than a year, so the OCD is likely to be ongoing for a couple of years already, and I don't think this will have any chance to heal. So now we're going to grab my grasper again. I didn't show you yet, but I have a special grasper who's it's a biopsy. You saw it a few times already, but it's a biopsy grasper, and I use it as a rongeur basically. But don't you see that I've bitten a little bit in my camera and stuff? Don't bite on the metal. And if it's too hard, then the thing breaks. Okay, so now that piece of bone there, which was a loose body waiting to happen, it's dead bone. And now we're just going to clean up the OCD bed a little bit more. The best thing about this OCD bed is that it has a lateral side to it. So as long as the lateral side of the bed is still okay, then this can heal quite nicely in younger kids. See how the bed doesn't go into the lateral column too much, maybe a little bit, not too much. So this for me is will become a stable lesion. I'll just clean it up a little bit more.
So how much do you clear usually? Once you know that it's enough, because you could remove a lot of more unstable cartilage, where do you stop?
This is of course the boring part of the surgery, but this is very important. There's still ongoing debate between ice picking and just debriding. I've only ice picked one because I wanted to have a little video of it, but I've never seen I've ice picked a few, but I never liked it too much because you get big holes in the subcutaneous, in the subchondral bone, and you always see some of the bone floating around once you've ice picked, and you can clean it and feel that you've gotten everything, but it sort of feels to me like these are little seeds for loose body. So I never liked that. So I've stopped doing it very, very early in my career. And just started debriding, and there was a study from I think Joaquin Sanchez-Tella was involved from Mayo Clinic, where they didn't see any difference between debriding and elbow OCD. Didn't see any difference between debriding and ice picking. So I felt acknowledged, and we kept doing this. So get rid of all the sclerotic tissue from the bed. And now Maurits, can you flex the elbow, flex it up a little bit? So when he flexes, you can see the crater there. Bear in mind that this is 4.5 millimeters. So this is about 4.5, 7 millimeters wide, and about, let's say 7 by 7, approximately. You can already see, because luckily the tourniquet is not very good in this hospital. I've been complaining about this for a long time, and now officially. But you can always see when I use this, you can see how it started. Sorry?
Oh, she has really high blood pressure. You can blame the anesthesiologist.
Oh, she has really high blood pressure. Yeah. She was a little bit scared before she went to sleep, but luckily she was happy to be in live surgery as long as she didn't want to see it. But the mom is going to see this probably, hopefully, and see what's happening. And I'm actually oh, can I grab my grasper again? I'm actually quite relieved with this because this is going to be a nice stable lesion, and she's only 14. She's old for OCD, but she's young for cartilage. So she will probably be fine. She will get some fibrocartilaginous lesion tissue in this crater, and she'll be fine. So post-op, I'm going to stop her from loading. I'm going to get her moving immediately tomorrow. I'm going to stop her from loading the elbow for about 6 weeks. And after that, she can start playing again and build up her athletic career if she wants to.
Roger, I have first a question. Are you tempted to
Yes.
fill these defects with minced cartilage or other biologics or whatever?
Probably.
What's your experience with this?
I have absolutely no experience with filling it up with mixed cartilage or with anything expensive and fancy, but I'm sure in the future it will be someone will find something to fix it. The problem with cartilage here is that it doesn't stick. So you can add some periosteum over it, for example, but there's been quite a few studies in the knee, and the knee guys and women are much better at this than we are. So we'll follow the research in the knee, and they are a little bit more commercial as well, I guess. So they don't mind trying. For me, I've not found it necessary in these patients, and I can only remember one little patient that didn't get back to sports where they wanted to. But we're not crazy sports like for example in Japan where they go back to throwing. We don't have throwing in Belgium, but volleyball, gymnastics, that's fine with this. So I have not seen the need for it, but I am watching the space because if someone finds a way to fill this, I'm sure that must be better than just leaving it and waiting for nature to fill this. But at the moment, I'm not sure if there's anything available that's better than nature. But I'm happy.
Roger, there's a question from Istanbul from the panel. There's a question. If you notice some lateral instability during your case and you didn't expect it before with the drive-through test, what would you do? Would you prefer an arthroscopic or open approach? From Kutalmi from Istanbul. Did you get it?
If there was instability?
If you notice lateral instability.
Was the question if there's instability during, and I see it during the case, so we do the arthroscopic.
Okay.
Yeah, that's easy. We described a method of doing this with PDS, and we actually do this arthroscopic, and that literally adds 3 minutes to the case. So that's very easy to do. We get a needle from the Rafael Koolpraat from Switzerland described the test, or published our first results, and he's publishing our later results as well. And so we get a needle, a PDS2, inserted into the ulna and inserted into next to the ulna antehumerus, and then we tie them together while locking the anconeus and lateral capsule inside. And our results have been very good. So that adds a few minutes to the case, but it does add a few months to the post-op rehab, because we do protect them a little bit. We don't let them go straight away. Whereas with this, besides the loading, this girl is going to get a splint, a little blue splint that some of you might have seen. She's going to get an exosplint for a day, and then tomorrow she can move. Okay, now let's mark the garrot off. Let's release the tourniquet and see what's happening. Huh? See if we're happy. Draaien. Yeah. Perfect. So the tourniquet is coming off. It always takes a little, or it starts bleeding straight away. And now when I use suction, we lose view immediately. So the Japanese flag sign in this case is a happy sign. So I'm happy with this. This is nice and bleeding bone, and that ends the case. So we still have 10 minutes for some questions.
Great. You're perfectly on time, Roger.
How much time do we have?
Brilliantly demonstrated. We still have 10 minutes. I mean, it's perfectly.
10 minutes. We can do another case, and then I won't talk and just do it.
In 10 minutes, yes.
No, it's fine. So Alex, my nurse, is going to close the wounds with just some Dermalon.
Roger, I think closure is very important as well. How do you close the wound? You use some do the strong closure?
I'll show you. Can we go back to the camera, to the light view maybe?
Yes, we have both views.
Both views, okay.
Because when
I don't close it because
I was told about
Alex.
Be careful about them.
So we just have a nylon suture, and Alex is closing the wound with one stitch we don't mind letting it bleed a little bit. I never use anything sticky on the elbow, so we don't use any scissors. We don't use anything that sticks on the elbow because I'm afraid of blisters. Well, you know, the swelling in this is negligible. There's almost no swelling, so she will be fine. But even then, we've stopped using any type of glue or anything on the elbow itself. We don't inject cortisone. Some people do post-op, or at the end of the case, you can inject cortisone as long as you don't inject it through the portals. We don't have the tendency to do that, but Peter Kakenbeker from Belgium has published a study, or is publishing a study, in over 100 patients where he had no problems with the cortisone and actually found some benefit in stiffness. So there is something to say about that, but we're not in the habit of doing it. She now gets just some absorbent bandage over it, and then she gets a crepe over that, and then she gets an exosplint, which is somewhere in the room probably, which is lying over there, and we use that for 1 day. That's our post-op.
Are you concerned about HO in this kind of case?
No, we're not concerned about HO. Oh yeah, my lovely nurse is showing you. Can you see it?
Yeah, a little bit higher. Your camera a little bit higher.
My head higher?
Yeah, that's better. That's better.
You can see the split. There you go.
That's the exo brace. You can buy it from my wife. So I do have a conflict. No, we're not concerned about HO. We don't necessarily give them anti-inflammatory drugs. Definitely not in the metacine for a couple of weeks. And in a girl like this, we just give paracetamol. She starts moving tomorrow, and physio if necessary in 2 weeks. And usually with patients like this, with little athletes, they do get physio, not to get them going faster, but actually to stop them a little bit, because they are very, very fanatical about it, and we want them to be cool for the first 6 weeks. And like as you saw when I got in, she's a little bit lax. So she's not going to get stiff. We're really not worried about her getting stiff. So we want her to just maybe stiffen up the elbow even a little bit in the beginning. Because there's bleeding now because the tourniquet is off, of course. But normally that's just clear fluid coming out of the elbow. All right. Any more questions?
What is her sport again, Roger? What is her sport?
Volleyball. She plays volleyball, which is unusual for OCD, but. Because 90% of patients that we see is probably gymnasts with OCD. We do have some swimmers, we do have some other sports, but volleyball is relatively unusual also because young people don't play that much volleyball in Belgium.
And when can she go?
Question is her laxity?
Expect to go back to sports?
Sorry, Gregory, what was that?
When can you give her clearance to go fully back to sports? 3 months?
Yeah, 3 months maximum. Well, usually they go back. Usually I can't stop them after about 6 weeks. The first 6 weeks I'm strict. I want them to not do any support. After 6 weeks, I let the pain decide. So if they're good after 6 weeks, I'm happy for them to do it. If not, then we wait a little bit longer. But 3 months is realistic.
Great.
Gymnast, I stopped them.
Roger, I think this was a brilliant demonstration. I think you showed us a lot of nice tips about patient installation, which is very important for elbow arthroscopy, of course. I don't think there's any more question on our side from the audience.
Perfect.
And thank you once again a lot for participating to this event. And we are
thank you for inviting me. It was fun.
The aim is really to expand this to many other surgeons and to have it much more accessible. So please don't miss the opportunity to become a junior member for free. So you have to apply today on the SECEC webpage, please. And the second important next event from the Education Committee will be on November 27th, and this will be the best Congress papers session. So please don't miss this and mark it in your agendas. Thank you very much, and I hope we see you soon for a new episode of the Surgeon to Surgeon event. Thanks, Roger.
Thank you.